Hinnell and the other presenters and those of you who have come here today to support and be supported by direct primary care. I've been asked to talk about the origins of direct primary care, and I have elected to also express some simple ideas that have driven my work in direct primary care, as well as the question of the role of DPC as a Trojan horse that can transform the rest of the healthcare system if we have the will and discipline to strive for this. Transformation. Although I could say a lot about the origins of the movement, I have only 10 minutes and will focus on the source of my own transformation. And I'm going to read this so I'll know it's going to time out. I can say honestly that if it were not for my son Michael, I would not be here. And you probably wouldn't be either. I was always interested in medical care design and ethics. But having a son with a brain tumor altered my perspective in ways that cannot be undone. I saw clearly the effort, the commitment, and the ability of those providing the care. And I also saw the remarkable lack of critical knowledge, commitment to service, and the needs of patients that their families and their families that was invisible to those providing the care. I will give one example. After over a month of continuous vomiting from a presumed gastroenteritis, Michael was seen by a pediatrician with an oncology background who did a CT scan and identified the cerebellar ependymoma. The day after this was removed, he awoke without nausea and with an appetite for bacon. We spoke with his nurse, who said that the kitchen was willing and able to supply this, but that she could not give them an order until the doctors finished their rounds. I was a practicing physician with experience with this quaint ritual, and I didn't understand why my son's needs and desires had to wait for the ritual to conclude. The nurses, doctors, and hospital felt otherwise. This started an inquiry for me that has lasted 30-plus years about what works and doesn't work in healthcare and why. My attempts to fix my own medical practice and redesign it for my patients led to intricate modeling of primary care systems to allow more time with patients, more room for urgent care, clearer promises, and better experiences for patients. Two of my partners eventually left our practice to set up MD Square, the first monthly fee practice in the United States, and at that time the first ridiculously priced primary care practice for over $1,000 per member per month, which attracted comments in the press about concierge care and boutique primary care. When I looked at the question of how to finance an optimized primary care system, I was attracted to the monthly fee concept because primary care is a fixed cost business, and a monthly fee could replace the fee-for-service insurance model with its remarkably foolish incentives and primary care toxic costs. I calculated the lowest monthly fee that could support a 600 to 800 patient panel, which I felt at the time was the largest panel size that I thought would work for me and my patients. The monthly fee for that proved to be $30 to $50 per patient per month, depending on age. And it worked both as a care model and a business model. Mitch Carton and I launched the new Seattle Medical Associates in 1997 and filled our practices in just over a year. I moved on to supporting a national movement roughly 3 years later with a board position on the American Society of Concierge Physicians, which is the only name we had for it at the time, started by John Blanchard, which later became the Society for Innovative Practice Design and eventually the American Academy of Private Physicians. In 2007, I co-founded Q Alliance, along with my cousin Erica and brother-in-law Norm Wu. We hope that this would be the first scalable, venture-backed model of direct primary care. We passed legislation in Washington State creating the new term, direct primary care, prior to opening queue lines. I helped establish the Direct Primary Care Coalition as part of an effort to incorporate direct primary care into the Affordable Care Act, which we accomplished. With the help of Jay Peace, who's in this room, bless your heart, and we'll be talking later, who remains the executive director of the lobbying organization. We have also been instrumental in passing laws in 23 states, defining direct primary care and clarifying that it is care and not insurance. We have active participation of bipartisan legislation in both the House and Senate of the United States right now, which will remove two massive roadblocks to direct primary care by defining direct primary care as a legitimate deductible medical expense in the IRS code and is something that can be purchased with an HSA, opening this care to millions of employed Americans. There was a hearing in the Ways and Means Committee of the House of Representatives 2 days ago, and our bill was one of the featured performers. There are thousands of other individuals who have put their shoulders to the DPC wheel and moving it into the thriving organism it now is. I wish that I had time to thank them all personally, but I don't. Simple ideas. These are distillations of things that I have learned over the last 20 years or so. First, what doctors do matters, for better and for worse. Our tools are powerful and our ability to help and injure patients is growing. You must at some point decide whom you work for. It will determine whether you go to a job or a mission every morning. A mission is more fun. Number 3, business models matter. They can reinforce or destroy your mission. Pick one that won't destroy it, like DPC. Look for a business model which incentivizes and supports your mission. No matter the business model, take the risk of doing only what works for your patients. It is a good discipline. If you want to understand why any business fails to take care of its customers, you will find it in the business model, including government, health insurance, healthcare itself, brokers, pharma, and others. 5, the point of medical care is not the destruction of disease, but rather the promotion of health. We have barely begun to explore and understand how this can be done. You should be aiming at that target. 6, it is more important to operate from promises to patients than from rules from textbooks and select committees. Be prepared to do both, but know which has priority. 7, walk into an exam room knowing what you plan to do. Diagnosis, coding, treatment, or something else. For me, it is to have every patient leave the room better equipped to create their own health. 8, choose empowerment over dependence. Know what your patients want and need before you tell them what to do. Give them the tools they need to care for themselves. 9, seek the truth about what medicine has and does not have to offer. Share that with your patients. You don't have to be the Wizard of Oz. Be real and transparent. 10, live outside of yourself as much as you can. Worry less about you and more about your patients. 11, Join this movement and its mission. Participate and inspire us. We need all the help we can get. 12. Walk away from the class warfare of medicine. It destroys all of our credibility and deprives our patients of options they need to know about. Trojan horses. Primary care has much more power than it realizes or wields. We do the referrals, and our patients trust us. We can, in all instances, work with and on behalf of our patients, or we can be the gatekeepers or the financial enablers of a dysfunctional healthcare system. The choice is ours. Almost nobody thinks that primary care can fix healthcare except me and a few others. I think they're all in this room. But if you look at Q-Liance, Iora, Our Health, Nextera, and others, they have been able to right the ship of healthcare. You will discover what is possible for this movement. The future. We can work together, or we can stay disorganized and powerless. We can fight over our relative purity and perfection, or we can understand that we possess neither, and that there may be many ways to serve our mission and many business models yet to be discovered that can promote and defend our mission while expanding our reach and our ability to serve all patients. Today is, for me, the end of the beginning of this movement. I'm not sure if I will see the culmination, and I am officially passing the baton to you. I'm old. It's time for everybody in this room to do the work, and you're already doing it. And one more thing, totally self-serving. I'm looking for a partner, and if there's anybody out there who's young and energetic and will allow me to be an old man finally, I would love that. Thank you very much.